Hello, everyone, wherever you're joining us from today. It's inspiring to see this growing global community continue to come together, families, clinicians, researchers, and advocates, all connected by a shared purpose, improving outcomes for children with neuroblastoma. Every webinar gives us an opportunity to learn from the leaders in the field and to better understand the research that is shaping the future of care. For families, these conversations are more than scientific updates. They help us navigate difficult decisions, understand emerging opportunities, and hold on to hope. Today, we are honored to welcome Dr. Giselle Sholler, a recognized leader in pediatric oncology and neuroblastoma research. Dr. Sholler is the founder and the chair of Childhood Cancer Consortium, BCC, an international network dedicated to accelerating developments of new treatments for children with cancer through innovative clinical trials and collaborations across institutions. Today's session will focus on BCC clinical trial update, where the consortium is today, what studies are underway, and how this work continues to expand treatment options for children with neuroblastoma. For families, understanding the clinical trials landscape is empowering. It helps us ask better questions, explore potential opportunities, and better understand the progress being made around the world. Dr. Sholler, thank you so much for being here with us today. We are grateful for your leadership, your dedication, your commitment to advancing care of children with neuroblastoma. We look forward to hear from you.
Thank you so much, and thank you for inviting me here. I'm gonna just get my slides up. Okay. Can you see my slides? Yes. Wonderful. Thank you so much for inviting me here today to be with you and to talk about our work through our consortium in high-risk neuroblastoma. This is just an agenda. I'm going to move this down so I can see all of my slides. There we go. What we're going to share here today, I want to introduce the Beat Childhood Cancer Research Consortium and who we are and how we have been working in the area of neuroblastoma. Talk a little bit about DFMO, our current landscape and future direction of where we're taking our research in this area. Then talk about how we are transforming frontline therapy, as well as our PEACH precision immunotherapy clinical trial that's focused on neuroblastoma as well as DIPG. Then talk about our information precision medicine program, and then some of the new trials that we have emerging in phase 1 and 2 trials for high-risk neuroblastoma. So we'll try and get through a lot today. I'm going to do my best to get this done in 1 hour. So the Beat Childhood Cancer Research Consortium, our mission is to reach every child everywhere with the new therapies and clinical trials that we're leading, both in clinical trials as well as molecular tumor board leadership and precision medicine in pediatric oncology, with a large focus. This consortium really started with our heart in neuroblastoma, and our goal is to for global expansion so that we can reach children everywhere, not just having children come to the US to our centers for treatment, but to deploy this throughout the world. We really work as a kind of an academic clinical research organization. We work with pharmaceutical companies. Our research do the preclinical work to bring new drugs forward. We work with the FDA to obtain IND approval, regulatory approvals, the protocol writing to develop the clinical trials, the data management, and then expand this out to all of our clinical sites, opening new sites across the US and internationally. We do all of the clinical and safety monitoring, supply logistics to get the medications where they need to be to reach the children. So it's a wonderful group, a team. This is our leadership team. Working together to create the vision for the whole program, and our lab team, where a lot of our clinical trials obtain biospecimens, tumor specimens to look at tumor markers and response. So this is our leadership here. And our focus is both on clinical trials to develop novel therapies for relapsed refractory cancers, as well as our precision medicine approach to really understand the biology of each child's tumor and to treat each child individually. We have reached children in 40 countries around the world. A lot of these children currently still have to travel to have access to our trials, but our goal again is to open more and more sites internationally. Here are our current clinical trial sites. We have sites across the US, about 50 sites, 8 sites in Canada, and we're expanding more in Canada as well. And this year, in 2026, we opened our clinical trials now in Spain, in Barcelona with Dr. Mora, and in São Paulo, Brazil, with Dr. Natalia Amber. We're so thankful to have them join the consortium and bring our clinical trials to South America and to Europe as well. We're hoping to expand next into Israel and just continue to make this work available to families everywhere. This is a list of our clinical trial, the 2 great trials we just closed this year. I'm going to focus on the clinical trials that we have that are for children with neuroblastoma in our talk today. So first, we'll start with a little bit of discussion of DFMO and where we started and where we are, just briefly with that. The rationale for bringing DFMO into neuroblastoma was to really see if we could find a maintenance therapy to prevent relapse. So our standard of care high-risk neuroblastoma involves induction with chemotherapy and surgical resection, followed by consolidation with transplant and radiation, and then immunotherapy and cisretinoic acid. And this has been our standard of care for a long time. And we can see that in doing so, we are able to achieve about a 55% event-free survival for children at 4 years. So our goal was to see, could we improve upon that? The way we wanted to do that was to look at how can we target the cancer stem cells? Because at the end of high-risk neuroblastoma treatment, our kids are in remission, but a majority of them are still a good portion of them were relapsing. And so what is a cancer stem cell? It's a cell that remains after treatment is given. It's usually a quiescent cell that can then cause relapse and recapitulate the entire tumor again, whether it's 6 months, a year, 2 years later. So how do we target those cells? We look at the stem cell pathways in cancer cells. We're really focused on this Lin28 overexpression. And we found that DFMO targets the pathway. It inhibits ornithine decarboxylase, decreases polyamines in cancer cells that then can suppress Lin28. If we can suppress Lin28, we then allow LET7 to be increased, which also then directly suppresses MYC-N. And so high Lin28 is a risk factor for neuroblastoma and associated with aggressive disease. If we can target that and decrease that, potentially we can target the cancer stem cell. What we saw when we looked at this in the lab, we saw that before DFMO, neuroblastomas have high Lin28, high MYC-N, and high stem cell markers. When we treated with DFMO, we showed a decrease in all of those 3 in our neuroblastoma cells in the lab. So we were targeting the cancer stem cell markers. What does that mean? Are we able to inhibit the neuroblastoma from growing? So what we want to see is neuroblastomas are actively growing cells. If we treat it with DFMO, can we turn these into sleeping or dormant cancer cells? The word we use for that is senescence. And what we showed in the lab in 5 different neuroblastoma models, that with increasing DFMO concentration, we increased senescence, or the senescent dormant state of the neuroblastoma. And that may reduce relapse risk. And so we also wanted to see, could we prevent tumor formation? And so when we look in the lab, we look at what we call neurospheres. Here's an image of a neurospheres. And I want to see if I can move. I have a bar at the bottom of that. No. Okay. Oh, there we go. So a neurosphere is a 3D cluster of tumor that can grow in the lab. And we can see when in the dark blue bar here, when there's no DFMO present, all of these neuroblastoma cells form neurospheres in the lab. But as we increase concentration of DFMO, fewer and fewer of these are able to form neurospheres. DFMO consistently and dose-dependently reduced neurosphere formation in multiple neuroblastoma models. Fewer neurospheres means fewer stem-like cancer cells, and potential for less tumor growth or relapse. And then okay, so to summarize all of the preclinical work, I just wanted to show a few things. DFMO inhibits ornithine decarboxylase, decreases polyamines, led to senescence and cell cycle arrest. It restored the Lin28 LET7, so took away the stem cell markers and suppressed neurosphere formation, resulting in a cytostatic response in neuroblastoma. We also wanted to look so if in mice models, we added DFMO to the drinking water, mice were implanted with very small amounts of neuroblastoma cells, so like a patient at the end of upfront treatment. And then some mice received regular drinking water, or some mice received DFMO in their drinking water. Most DFMO treated mice remained tumor-free, suggesting that DFMO helped stop tumor formation at very early stages in the mice. And so now let's bring this to our patients. I hypothesized that after our standard upfront chemotherapy, surgery, transplant, radiation, antibody treatment, and CISRA, so all of the upfront treatment for high-risk neuroblastoma, what if, since the majority of patients relapse within the first 2 years, what if we had them take DFMO as a pill in the morning and night for 2 years? This is one little girl taking her first dose of DFMO in applesauce. Our primary objective was to look for event-free survival after 2 years and overall survival as a secondary after 2 years. And what we saw that based on historical control, and you can see down in the bottom corner here, this is the curve from the Children's Oncology Group with standard of care with immunotherapy. The gray bar is during immunotherapy, but we can see even after the gray bar, those first 2 years is a significant relapse rate. And so our study showed that we had at 2 years and 4 years, about 85% of children still staying in remission. And then what was most important, we had 95% of children still alive at 4 years. So this was very exciting, but this was without a control arm. And so we wanted to look and see, could we find a control arm? We found that the majority of our patients had come directly from the COG AMBL 0032 study, the curve I showed below. 92 patients came directly from that study. So we were able to obtain the raw data from the Children's Oncology Group and identify patients who completed that study and would have qualified to enroll on our study, but did not. So same patients, but did not receive DFMO. The patient characteristics were quite similar. And when we looked at that whole group comparison, we saw a significant improvement in both event-free and overall survival. With 4 years, 84% of children in remission on DFMO versus 72% without DFMO, and then 96% of children alive versus 84%. This was very exciting, but the FDA asked us to look even more closely at that data to match patients. So a propensity score match looks at first over here, the qualifications that may change outcomes. So we matched patients based on their risk characteristics on the left. And we took, for every one of our patients, we found 3 patients in the control group, in that 800 group patients, that matched exactly on McN, and then matched by a covariate score for the other 10 factors. So we can see 45 of our patients that were McN amplified, or half the patients that were McN amplified, matched to 3 controls versus not. And we looked at that. Then the population characteristics are actually matched almost exactly because they are now matched patients. And we saw that the event-free and overall survival were similar results, showing again a significant improvement in event-free and overall survival. This resulted in FDA approval for DFMO December 13th, 2023. The medication now is called iWilfin after Will and Finn, who were 2 of our children on DFMO. Will's father was the one that actually funded the very first phase 1 clinical trial with DFMO. Will was the 3rd patient on that phase 1 trial after being told he was incurable and is in college now today, doing wonderfully. And Finn also was a very important little boy with DFMO, also had an ALK mutation, and so received that combination and is doing very well today. The indication for approval is to prevent relapse for patients with high-risk neuroblastoma after immunotherapy. And so that is now available by prescription here in the US. It's also available by prescription in Israel, Switzerland, and Australia, has been approved commercially through those 3 countries. For all other territories, I know a lot of families here are interested in the DFMO. It's for countries where it's not commercially approved. There is access through US WorldMed's named patient program in partnership with the TANA Pharma Group. The request should be initiated by your treating physician, and there's the email to have access to DFMO. While it's not available on our trials anymore for high-risk neuroblastoma up front as maintenance, we do have clinical trials ongoing for maintenance for patients who have medulloblastoma, Ewing sarcoma, and osteosarcoma. So patients with those diseases are still able to obtain the medication through a clinical trial, specifically for those. There are two special countries in Japan and in China. They have regions where they have not formal regulatory approval, but Japan has a partner clinical trial program through National Children's Cancer Center in Tokyo, and their email there for contact. And in China, it's available through their pilot zone commercial access through Shanghai Children's Hospital. And there's a contact email there for families in China to access DFMO for upfront patients with high-risk neuroblastoma. There's a couple of other topics I wanted to just share. At ASCO this year, we do get some questions about patients who have CNS disease for relapsed with high-risk neuroblastoma in the brain. And we did share some of our results. So we do have an expanded access for patients who have brain relapse because those patients do require a higher dose. And we do see that here the event-free survival for patients who came on study with active brain disease, we have a 46% EFS at 4 years, and 31% who had CNS but had it resected and then came on. And then the overall survival for both is between 55 and 65%. So still long-term survival for patients with neuroblastoma spread to the CNS, and this is a very challenging group of patients. So some of these patients were treated with concomitant or other treatments as well, which we can do on our expanded access program. The one caveat for this is we do see increased AEs related to both hearing loss, which on a lower standard dose is around that 5-ish%, and hearing loss in this dose level is 25%, and anemia also 28%. So higher, those are both dose-dependent side effects, but important ones. And then also we looked, some families ask about patients who have ALK mutations or ALK amplifications. We do have 9 patients who enrolled at the end of conventional high-risk neuroblastoma, as Finn did. 8 of these remain in remission with 2-year EFS of 89% and 100% 2-year OS. ALK mutation amplification is a higher risk category, and we do recommend ALK treatment with an ALK inhibitor in combination with DFMO at the end of upfront treatment. These were very well tolerated together with kind of standard expected adverse events. So, that's kind of where we are with upfront treatment or maintenance therapy for DFMO. What is next? We currently have another clinical trial open, BCC 020, for phase 1/2 study for DFMO in combination with AMXT for relapsed refractory neuroblastoma, brain tumors, and sarcomas. So why AMXT? So DFMO inhibits the polyamines inside the neuroblastoma cell, but neuroblastomas or cancers can still take up polyamines from the bloodstream. And so AMXT is a medication that is a polyamine transport inhibitor that lowers the polyamines inside the cancer cell because it blocks the cell's ability to take up. So when we do dual anti-cancer treatment with both of them, we disrupt the tumor cell growth, and this also enhances the immune system recognition and attack. We first studied this combination in 2013, a long time ago, combining both the DFMO and AMXT, and showed that we were able to see synergistic activity across multiple neuroblastoma models, and with greater growth inhibition together than either drug alone. If we look on the far side, that purple line shows there's near complete suppression of tumor cell growth in 3 different neuroblastoma cell lines in the lab. Back in 2013, we were hoping to move this forward to a clinical trial, but the drug had not yet been even in humans yet. So we had to wait for first in human studies and then the adult studies. And in 2023, the company reached out to have us work on a clinical trial with them. And so during that time, others have studied this combination, both Dr. Haber's group, Dr. Ziegler's group in Australia. Both this study showed that the references at the bottom show that in neuroblastoma models, the combination of DFMO and AMXT in animal models had the longest survival. As well, they showed that in the cell lines, we can see in the tumor formation assay, tumor colony assay, we can see that the combination had very few tumors formed. They also studied this in DIPG, and this is my only slide that's not neuroblastoma, but it was really exciting to see the effect because this is also a very challenging pediatric cancer, but with the DFMO blocks production of the polyamines, AMXT blocks the uptake, and we see less tumor growth, and longer survival in this DIPG models. And so our clinical trial is I'm just going to focus, it's for multiple different tumor types, but I'm going to focus on just neuroblastoma. It's for high-risk neuroblastoma that's either relapsed or refractory. By refractory, we define this as patients who fail to achieve a CR after a standard upfront treatment, had progression during upfront therapy, or they have disease remaining after a standard immunotherapy. And patients are eligible to enroll with either active disease or no active disease, because we do know that patients who have relapsed, even if they can get back into remission, let's say we surgically resect the tumor, their risk of relapse again is very high. And so if for patients who have come on with no active disease, they do need to meet the following criteria. They have to enroll no later than 60 days from their most recent therapy. So there's 2 months from end of treatment to enrolling on this study. Patients with active disease need to have received at least one treatment for relapsed refractory disease, and they are stable or better on that treatment. And they must not have any disease in the organs, such as lungs, liver, or brain. The first phase of the trial is a phase 1 clinical trial to evaluate safety, tolerability, and determine the recommended phase 2 dose of both AMXT and oral DFMO. And the secondary objectives, we're going to follow progression-free survival and overall response, as well as pharmacokinetics of the drug. So we are going to be testing 5 different dose levels in the phase 1 portion. We are currently starting at the 350 milligrams per meter squared of AMXT and 300 milligrams per meter squared twice a day of DFMO. And that's the dose level we're currently on at this point in time. And then in the phase 2, once we determine that dose, as you can see, there'll be multiple cohorts. So not just neuroblastoma, but ETMR, ATRT, DIPG, Ewing's, and osteosarcoma as well are eligible for this. But specifically, the neuroblastoma cohort will be a randomized. It's going to be looking at both DFMO alone or AMXT and DFMO, because we do know that DFMO alone does have an effect in neuroblastoma patients in preventing progression. Patients do, though, if they do progress on the DFMO alone arm, are allowed to cross over and receive the combination. So everyone will have the opportunity to receive the combination of DFMO and AMXT in the phase 2 portion. Currently, the phase 1 portion, everybody is receiving the combination, and we do expect the phase 1 portion will take at least 1 year to complete. We do have some exploratory objectives. We'll be looking at analysis of the tumors, as well as circulating tumor DNA in the patients. And we'll be studying the polyamine inhibition on immune regulation and cytokines in the patient's blood, because there's preclinical work showing that the DFMO and AMXT combination increases the immune effect on the cancer cells as well. And we'll be following the cardiac indices for patients on this combination. This is currently where the study is open. The green sites are open to enrollment. The yellow sites are in process of opening for enrollment. We do have one patient that has just enrolled on this clinical trial. So DFMO stops tumor cell growth, but it doesn't kill the tumor, as we've mentioned. It induces senescence. And so we wanted to look, could we then use that to create a 2-hit strategy? First, arrest the cells, then eliminate them. So there are medications available called senolytic agents, such as venetoclax or navitoclax. They target and eliminate cells that have become senescence. And so looking at this in our lab, this is work done by our PhD student, Tarlin, who is just absolutely wonderful, where first treated the neuroblastoma cells with DFMO by themselves for 4 days and induced the senescent state, then added venetoclax to this treatment for a day and a half. And we can see in the bottom left corner that the cells that received the DFMO and then the venetoclax resulted in cell death, so which is what we were hoping to see. When we look to mark as a marker of the cell death, we look for caspase activation within the cell, and we can see that without DFMO, um, venetoclax alone, that drug doesn't really cause cell death. But if we do DFMO first and then venetoclax, then we're able to sensitize the cells to make them more sensitive the the venetoclax and induce significant cell death. Um, and why does this happen? One of the mechanisms that venetoclax, when it's a BCL2 inhibitor, but in many cancer cells, they will exhibit MCL1 as a resistance mechanism, and that's why they're resistant to the venetoclax. That's why the venetoclax alone on neuroblastoma cells, we don't see the effect. So we wanted to say, does DFMO remove MCL1, which is a protective shield for cancer cells? And we saw that it does. And in 5 days of treatment or in 4 days of treatment with DFMO alone, when we measured MCL1, the shield that protects the cells from the venetoclax, we see by day 4 and even day 5 that the DFMO is decreasing MCL1 in the neuroblastoma cell and then allowing the venetoclax to become affected. So this is a really novel and new combination, new way of really treating neuroblastoma. So our animal models are underway to understand this application in vivo because the timing and schedule of these medications are clearly going to be very important, where one medication has to be given first before the second. And we're already looking at designs for potential phase 1/2. So this is where we are in DFMO in pediatric cancer right now. We've shown it induces senescence and prevents relapse. We now have a new clinical trial with DFMO and AMXT for dual targeting for greater impact, and moving forward into the future with DFMO and potentially venetoclax are different ways to induce cell death. So that's our DFMO story. We're going to move on. So our consortium also is looking at how do we want to treat high-risk neuroblastomas from beginning of treatment all the way to the end. And we currently have a phase 2 study looking at naxitamab added to induction therapy for subjects with newly diagnosed high-risk neuroblastoma. Our study chair for this is Dr. Krivecka, who's a really wonderful, wonderful collaborator and partner in this journey. So this is really built upon St. Jude's work, who when they published and showed that improved outcome for children with newly diagnosed high-risk neuroblastoma using chemoimmunotherapy as upfront induction therapy. They showed in their study that instead of an end of induction response of 67% achieving VGPR or greater, compared to the historical control of 42%, and for their end of induction response of PR or greater, was 95%. So 95% of patients at end of induction, when you added immunotherapy to upfront treatment, was 95% of patients had a greater or equal to partial response versus the historical of 75%. So we were looking at which antibody we wanted to add to upfront treatment. And because many of our patients are receiving dinutuximab after transplant, we wanted to have a different chemo antibody upfront. We looked at the mechanism of action of naxitamab. Naxitamab is the humanized anti-GD2 monoclonal antibody developed at Memorial Sloan Kettering that binds highly expressed GD2 on neuroblastoma cell and reduces tumor cell and induces tumor cell death through immune-mediated mechanisms, both through antibody-dependent cellular cytotoxicity and complement-dependent cytotoxicity. This drug received approval by the FDA in 2020 in the US. And so the approval in the US was based on relapsed patients. They did 2 clinical trials showing an overall response rate of 45% or 34% for relapsed patient. And naxitamab demonstrated a meaningful response rate in heavily pretreated patients with relapsed refractory high-risk neuroblastoma. And so this is a drug that we wanted to move forward into our clinical trial. Our study design for BCC 018 is a standard 5-cycle induction chemotherapy with naxitamab added starting in cycle 1 through cycles 5, with an end of induction response evaluated after surgery. Is planned following cycle 4, but may be delayed to after cycle 5 if clinically indicated. The study objective is to evaluate whether naxitamab added to the standard backbone improves early response rates in newly diagnosed high-risk neuroblastoma. There is a bridge chemotherapy if patients are not in complete remission at the end of induction after 5 cycles. Patients may continue to receive an additional 6 cycles of irinotecan, Temodar, nab-sirolimus, with a goal of having all patients in complete remission prior to moving on to consolidation. Um, so the study objectives, it's a phase 2 multi-center international trial with newly diagnosed high-risk neuroblastoma. Our goal is to enroll up to 92 patients to obtain our 83 patients evaluable subjects. The primary endpoint is complete response rate as assessed using the 1993 criteria so that we can compare to previous outcomes. And here is our overall treatment schema for Beat Childhood Cancer Consortium for high-risk neuroblastoma. The 018 study is really just an induction trial looking at response rates at the end of induction. And again, there is that bridge that can be added as well, but this is the standard expected. Then we have our consolidation with transplant and radiation therapy. That is not part of our clinical trials. That is standard of care. So some patients are receiving tandem, some patients are receiving Bumil, some patients don't elect not to receive transplant. We also then have our OAK-12 clinical trial, and so this trial is going to be open internationally as well. The 018 is our clinical trial that is available in Europe and South America, and then O12 will also be available in those countries, and this will be a potential mechanism also of accessing DFMO as maintenance therapy. Patients need to enroll after radiation therapy and can then are randomized to either receive DFMO with immunotherapy or immunotherapy as standard care. But all patients will then also receive 2 years of DFMO afterwards. The question for this is, do patients, because about 14% of patients relapse during immunotherapy, can we prevent more relapses during immunotherapy to improve event-free and overall survival for children with high-risk neuroblastoma? So both of these trials will be available both in Europe and in South America. So currently, 018 is open, officially open in all of these countries that are in green. Spain will be open probably in a week or so. It's very, very close, just a few regulatory documents, that's my understanding, and available in Quebec as well. And then the 012 study is available. It will be available in all of these. So the green ones are the countries where it is currently available and states, whereas the yellow is in process of opening, but that's as are expected. And so now I'm going to move on completely different tangent and talk about our BCC Precision Medicine program. So our information project is not necessarily a clinical trial that gives a particular drug. It's a biology study, information to try and learn as much information from each child as we can to be able to give the best recommendations for treatment for each child and their family. We are collecting a database of clinical information, patient responses, as well as whole exome, whole transcriptome sequencing of all patients' tumors, relapse diagnosis, to have a bioinformatic analysis and evaluation, have molecular tumor boards. We also do research in the lab, growing the cell lines, xenograft models to test our recommendations and collaborate and share all of our data, our cell lines with others. Anyone that is interested in doing pediatric cancer research, we want to encourage more and more labs to participate. Our vision is that all children with cancer will have complete genomic sequencing at diagnosis and at every single relapse, because information can help us understand each child and their cancer to better improve outcomes. Why is this so important? The precision medicine tailors the right treatment to the right patient at the right time. Historically, our treatment is one size fits all. One diagnosis, neuroblastoma, everyone gets the same treatment. But we know not every child is going to respond correctly to that treatment. And so it's really important to understand the molecular drivers that are specific to each child. What are the target therapies that might help that child? And with our technology integration, leveraging AI and sequencing and digital tools, we're better and better able to understand how to treat each patient. It's important to understand what are the different forms of genetic testing and why it matters. We get a lot of questions about this. My child already had genomic sequencing. but that child only had a panel of DNA mutations looked at, not the full depth of there is a difference. Whole exome, whole transcriptome looks at 23,000 different genes of the patient's tumor. And the DNA tells us what's mutated, but the RNA is incredibly important because a mutation may turn a gene on or may turn it off. And then downstream, the RNA tells us what pathways have become activated or not activated in that patient's tumor. And that can completely change how you would treat that patient. Understanding germline versus somatic, it is important to test the blood also to look at what DNA mutations a patient might carry that might impact not only their siblings, but how to treat that patient. And then tumor profiling versus liquid profiling. We do circulating tumor DNA now for all of our patients, but it's important to look at when you're doing a blood test, a liquid biopsy to ensure that it's not for just a specific mutation that may or may not be present, but whole exome again, whole transcriptome, getting deeper. So when you're having your child's tumor sequence, it's really important to understand what they're sequencing, how they're doing it, what the analysis, what the bioinformatic background is to really analyze it. So our Precision Medicine and Biobank Initiative is really a whole group to look at not only bringing in the tumor, but to have an international molecular tumor board really looking at not just the physicians, but the pharmacists and the bioinformaticians all together and the clinicians to help create a correct treatment plan, but also to bring these tumors to the lab to study them, to verify, to help us grow and learn. I'm going to just skip that one. And so when we have a patient biopsied here, we do whole exome, whole transcriptome. We have a molecular tumor board approach. The sequencing takes about 2 to 3 weeks before we can have a molecular tumor board to then discuss the patient's care. We invite their local physicians onto the call as well to be part of the discussion to create individualized treatment plan. An important part of this is the pharmacists, because as we pull together drugs that may not have been combined together, we need to look at drug compatibility, safety, what are all of the things that we need to follow, and how to put those drugs together in a treatment plan for each patient. This is kind of the molecular tumor board, all of the things that we discuss. And again, the pharmacist review is critical and important to help us pull together that plan. These are just the RNA. We look at the different pathways. So essentially, all children care here at Penn State should have cancer, diagnosed with cancer or at relapse, have genomic sequencing. The tumor sequencing, blood, tumor DNA, as well as pharmacogenomic sequencing. That tells us the sequencing of the patient's normal DNA to let us know how they're going to metabolize medications, to be able to address dosing up or down, depending on how well they will metabolize different medications. And then the precision supportive care, I think that's also incredibly important. Our integrative medicine team will meet with the family as well as our exercise therapists and psychology to really support the patient in a individualized treatment way as well. We have held over 200 molecular tumor boards since 2021. Internationally for patients, not only at our site, all of our BCC sites, and actually these are the sites that are participating currently in the precision medicine program, and the sites that are about to open. So then I'm going to shift to our precision immunotherapy trial. Our BCC 017 study is a collaboration between our site here at Penn State, as well as the University of Florida. We're really thankful to work with Dr. Dwayne Mitchell, who has really led this work in adult cancers, bringing precision medicine and immunotherapy together. First, our goal is on this trial is to have a biopsy of a patient's tumor. And then do I have another? No, I'm just going to show you. We have a biopsy of the patient's tumor. That patient's tumor is then sequenced using our precision medicine approach that I just mentioned to have a molecular tumor board. At the same time, a piece of that tumor is sent to the University of Florida, where the RNA is isolated from the patient's tumor. We also do a leukapheresis. Sorry, I want to here. We do a leukapheresis of the patient's blood. The patient's dendritic cells, their own dendritic cells, are pulsed with a tumor mRNA to create a personalized dendritic cell vaccine using the patient's own immune system and their own tumor mRNA. And so at that first biopsy, we're able to do both the precision medicine sequencing and create a dendritic cell vaccine for that patient. This does take, sorry, not sure what's happening. Uh-oh. My PowerPoint stopped working. I'm not sure what's happening. So I'm just going to keep talking. So the patients enroll on the study and they have their, I don't know what I'm hoping the program will start responding again. This is unfortunate. So once the patient enrolls on study, the tumor will get sent for sequencing and will get sent to make the vaccine. The patient then starts to receive the precision medicine therapy that the tumor board has received. So they get the personalized therapy for about 2 cycles while the dendritic cell vaccine is being made. Then we receive the dendritic cell vaccine. The patient will then receive the vaccine number 1. 2 weeks later, vaccine number 2. At this point, the vaccine has primed the patient's own immune system and activated their T cells against their tumor. So after dendritic cell vaccine number 2, 2 weeks later, the patient will have a leukapheresis again. We will isolate the patient's T cells to go back to the lab to create a personalized, essentially CAR T cell, but their own T cells activated by their own vaccine. We grow that into the lab. Again, while we grow up those T cells, it takes about 2 months. They start to again receive the personalized treatment that we had planned for them. When their T cells are ready, they will be sent back to us to then give the patient their essentially their own personalized T cells activated against their cancer. I'm going to just pause here for a moment. So the primary objective of this trial is to look at because this is a phase 1 study, we're looking at the dose-limiting toxicities and the maximum tolerated dose of molecularly targeted therapy in combination with the adoptive cellular therapy. So we are looking at the safety and feasibility, as well as following for progression-free overall survivals, as well as overall response rate. In terms of eligibility for this trial for the neuroblastoma patients, these are patients who have relapsed or progressed during standard of care therapy and have been non-responsive to or progressive despite acceptable curative therapy, and they have to be greater than or equal to 12 months of age at enrollment. It does have a biopsy requirement for the tumor biopsy and confirmatory diagnosis, as well as confirmation of tumor RNA extraction and amplification. The tumor requirements, the tumor must be measurable disease at the time of biopsy. The tumor must be accessible for biopsy. And the tumor sample must contain greater than 20% viable tumor tissue. Bone marrow patients with only bone marrow disease are eligible if the bone marrow involvement is expected to be greater than 20%. That is able to be used for the biopsy. Subjects who are expected to have no evidence of disease after surgical removal of their tumor. For example, if a patient relapses with just one lymph node in the axilla and we remove the lymph node for the biopsy and for the sequencing, that patient is still eligible to participate on the trial and receive their vaccines. Again, this is discussed. This molecular tumor board. So the dendritic cell vaccine, I shared previously how the dendritic cell vaccine was being made. Again, the leukapheresis, patient's white cells are leukapheresed, isolated out, and then the RNA is pulsed into the immature dendritic cells to create a mature dendritic cell vaccine. Once the vaccine is given after 2 weeks, then the patient again has a collection of their T cells. The T cells are the killer cells that will then be able to attack the tumor cells. The Manufacturing of the T cells happens in step 3 here. They're grown in culture with presence of additional dendritic cell vaccines while the patient is getting more precision medicine. The patient then, to be given these T cells, they undergo lymphodepletion with cyclophosphamide and fludarabine because we want to remove your immune system has regulatory T cells and active T cells. We want to get rid of the regulatory T cells so that when we give the activated T cells at 24 hours after that, they are able to attack the tumor and are not regulated. And then we continue after the activated T cells, patients can get up to 10 vaccines of their own personalized vaccines. And then just a couple of clinical trials that we have early phase 1, phase 2 trials. One is a phase 2 trial with naxitamab in combination with a drug called tipifarnib for relapsed refractory neuroblastoma. So we all know what the anti-GD2 immunotherapy, both naxitamab, girentuximab, or girentuximab beta, are available. This clinical trial is currently using the immunotherapy girentuximab to bind to GD2 on the neuroblastoma cancer cells and result in immune-mediated cell death. But the immune system is necessary to be present to activate the cell death. What we see in neuroblastoma is it's often an immune cold area in the tumor. Tipifarnib is actually an HRAS target. It's a farnesyltransferase that blocks post-translational modification of HRAS. And so it is a drug that is used in cancers as an HRAS, targeting the HRAS pathway, decreasing proliferation, increasing apoptosis. But what our team, Dr. Wang, H.G. Wang, in here at Penn State has studied this drug and its ability to block extracellular vesicles being secreted by neuroblastoma cells. By blocking these extracellular vesicles, these are critical regulators of tumor growth and progression and promoting metastasis. They also regulate the tumor microenvironment, which is important when we're looking at anti-GD2 therapy. The tumor microenvironment is suppressed when these vesicles are present. It decreases NK cell maturation. They decrease the NK cell infiltration into the tumor microenvironment and increases tumor-associated macrophages, which suppress the immune system, which results in reduced anti-GD2 killing and immune killing. Tipifarnib suppresses these extracellular vesicles, and our hope is that it will then result in decreasing the immunosuppressive tumor environment, enhancing the effectiveness of anti-GD2 therapy. And Dr. Wang's lab showed that this is true. The tipifarnib reduces the secretion of these extracellular vesicle. It reduces the immune suppression. It enhanced NK cell activity, NK infiltration and killing, and decreased the tumor-associated macrophages. And in animal models showed that it improved anti-GD2 response with the lowest tumor burden seen in mice with naxitamab and being treated with both naxitamab and tipifarnib, and resulted in longest survival with the combination therapy. And so our hypothesis again is that treatment with tipifarnib and naxitamab will increase overall response rate because tipifarnib would inhibit the extracellular vesicles and improve the immune tumor microenvironment and enhance the anti-tumor activity of the naxitamab. So the eligibility criteria for this trial are for children less than 21 years of age at initial diagnosis and greater than 12 months at age at enrollment. We are required to do a safety run-in, I think that has just completed. The first 6 subjects were required to be greater than 6 years of age, and I think we just enrolled the last one. And our disease status has to be relapsed refractory neuroblastoma with active disease, measurable as tumor greater than 10 centimeters by CT MRI, or positive by MIBG or PET imaging, or positive by bone marrow aspirate or and biopsy. Patients with neuroblastoma spread to the CNS are eligible. Steroid dose must be stable for greater than or equal to 1 week prior to biopsy, and no evidence of progressive hydrocephalus at enrollment. And tumor assessments need to be completed within 4 weeks of first study enrollment. The safety run-in, again, is for the initial first patients were required to be greater than 6 years of age to assess dose-limiting toxicities and treatment feasibility. The primary endpoint for this study is overall response rates. Secondary endpoints are duration of response, event-free survival, and overall survival, and to characterize the safety and tolerability of this group of patients. And there are exploratory objectives that we'll be looking at the genomic sequencing analysis and circulating tumor DNA and immune markers in these patients as well. Here is the study design. It's an open label, multi-center phase 2 study. Patients will receive 6 28-day cycles of tipifarnib in combination with naxitamab, with evaluations after every 2 cycles, and here's the dosing. It's currently open at 12 sites across the US. 8 sites are pending activation in addition to that, and we've enrolled 8 patients to date. Then the other clinical trial that we currently have as a phase 1/2 study for neuroblastoma is silmucertib in combination with chemotherapy. Silmucertib is a CK2 inhibitor. CK2 activity is very high in cancer cells and implicated in cell biology in multiple different pathways. And so it really targets not just cell growth, but preventing apoptosis, driving tumor suppressive functions, and transformation as well. There are diverse neoplastic cells are addicted to the presence of high CK2. CK2 has been correlated with high-risk clinical features and poor survival in the bottom left corners. Patients with neuroblastoma, we see that patients with high CK2 pathway have a much lower overall survival probability, and it is very highly expressed in the majority of pediatric neuroblastoma. In some of the work done by Dr. Chandrika Bohora's lab here at Penn State, this is a trial as a result of her preclinical work, showed that with the CK2 inhibitor present, it decreased neurosphere formation, decreased tumor formation in mice. And here in the animal models, we show an increase in progression, both with CK2 alone and then with CK2 combined with irinotecan and Temodar, significantly more increased survival in the animal models. And so irinotecan and Temodar is the drug combination that has been chosen to be combined with the CK2 in our clinical trial because we were able to show synergy in our preclinical models. So this is first a phase 1, then phase 2 clinical trial. The phase 1 is to characterize the safety profile of this drug in combination with chemotherapy and to determine the recommended phase 2 dose. And then to also evaluate the pharmacokinetics of this drug and to evaluate anti-tumor activity. We are just at the point where we're completing the phase 2, and so we will be moving on to the phase 1. We will be moving on to the phase 2 trial very shortly. The phase 2 trial will evaluate silmucertib in 2 separate cohorts. The first cohort will be for relapsed refractory neuroblastoma, and the second cohort will be Ewing sarcoma. And the primary endpoint is to look at overall response rate for patients receiving this combination. The secondary endpoints will be to look at disease control rate, progression-free survival, and overall survival. There are a lot of exploratory aims looking at the pharmacodynamic modulation of CK2 activity in the blood, as well as circulating tumor DNA, and then cancer biomarkers to see if we can look at sensitivity or resistant markers, as well as biospecimen banking. This is for children aged 30 years or less at initial diagnosis. All subjects must have confirmed diagnosis of neuroblastoma, and the disease assessments for eligibility must be done after the last dose of any previous therapy and also within 4 weeks of enrollment and beginning study drug. So here's the study design. The phase 1, there's 3 dose levels. And again, we have just completed the phase 1 portion of this trial, and we'll be moving on to the phase 2. The phase 2 is going to be an efficacy study combining irinotecan and Temodar for the neuroblastoma. For the Ewing sarcoma patient, it'll be vincristine, irinotecan, and Temodar. Here are the sites that currently have this trial open in the US, with 12 sites are open and 10 sites are pending activation as well. And we currently have 21 subjects that have enrolled on this study to date. just one future direction. I think we're exactly on time. Wow. We are moving forward here with a national platform for personalized cancer cell vaccines using an RNA vaccine with lipid encapsulation. There's a lot of research going on in our beach childhood cancer lab right now looking at a both off-the-shelf personalized cancer vaccine for different each diagnosis to be able to be given ideally early in treatment, and then we're working with the University of Florida to then also develop personalized vaccines similar to what we were looking at in our PEACH trial, but instead of dendritic cell to be lipid encapsulated so that we can create those and have them available for patients at the end of their upfront treatment. So this is a really big push that we're working on. Our hope is to have this available in the next year and a half into a clinical trial. That's a big focus of our beach childhood cancer work preclinically right now. And we are on time. I know that was a ton of information, but I wanted to give a little update on all of the different things that we're working on for patients with neuroblastoma. I want to thank you to all of our donors and our grants and our supporters that are really making all of this work and other work in the other sarcomas and brain tumors that we're working on as well. So thank you to all of them, but really thank you to the kids and families that participate and share their children with us. And I will stop there and take any questions. And we do have a little bit of extra time if needed. Thank you. Okay, and so in the Q&A, so that one of the first questions we have is it risk to treat neuroblastoma with stem cell transplant if the stem cells themselves can cause a relapse? So there has been work done here in the US with the Children's Oncology Group. They did do a study that looked at, because we do collect stem cells early, some of those stem cells may have neuroblastoma. They did a trial where they purged the stem cells that were collected to remove any GD2 positive cells and showed that there was no difference in outcomes. So it is felt to be safe currently. One of the things I did not mention here is that we are looking at a clinical trial to remove transplant for patients with high-risk neuroblastoma. Our hope is that if we're able to add that antibody up front and add the DFO on the back end, can we, by using less toxic, more targeted therapies, hopefully be able to take away some of our more toxic therapies like stem cell transplant. So we will be moving forward with a clinical trial to see if it is safe to remove transplant. Right now, the standard of care is to continue with transplant. But thank you for that question. And so the next question is, I understand that the COG high-risk neuroblastoma does not add anti-GD2 until cycle 2 due to concern for tumor lysis. Do you have any concerns starting naxitamab in cycle 1? I can say that we have 33 patients currently enrolled on our trial, and that has not been a concern. We would almost like to see tumor lysis occurring and that much cell death is actually occurring. Neuroblastoma is not like leukemia, where we do see tumor lysis, and that is something that we have to manage in leukemia with extra fluids and other things. But for the 30 patients so far, we have not seen tumor lysis as an issue, and that giving the naxitamab antibody therapy with cycle 1 has been perfectly safe. And then another question we have, can a patient who does not respond to one anti-GD2 antibody still respond to a different anti-GD2 antibody? Yes. So we have seen patients, especially relapsed patients who progress on one of the anti-GD2 therapies and we change. They are different molecules and they are different compounds. And so while a patient may build resistance to one, that's why in our clinical trial, we really felt it was important to have one of the anti-GD2 upfront and then a different anti-GD2 in maintenance therapy. Because if that patient becomes resistant to the first anti-GD therapy upfront, in maintenance, they may not be really receiving an effective treatment. So it's really important. But we do see, and I think that for a relapsed patient, if you are progressing on one, it's very reasonable to try the different immunotherapy because we have seen patients who were refractory to one respond to the other. Okay. Another question. Are patients still only given 2 years of DFMO? Is there any benefit to continuing post the 2 years? Great question, and we get that question a lot. we, started with 2 years, and the goal was to then observe patients post the 2-year time point to see if we started to see were we just delaying the relapse, and was the relapse going to happen after we stopped? But we haven't seen that to be the case. The even out to 8 years now, the uh, relapse, the prevention of relapse is sustained. It doesn't seem, there are a few patients who relapse post 2 years, but it is very few and far between. So we don't feel like it's necessary to continue. The majority of relapses that occur very early, and then after 2 years, we see very little. So we are continuing just with the 2 years of the DFMO. The plan was that if we did start to see relapses after, we would extend it, but that hasn't been the case. But great question. What trial would you recommend for a 23-year-old patient? So it really depends on the amount of disease that patient would have, where the disease is, and what the patient's medical history to date has been, and what they've received. So I would be happy if you want to email me to discuss that one with you. But a specific case takes so much work to look into everything that they've already received. Is there any genomic sequencing available to help us understand really what's the best treatment? Do they have high CK2? Do they have high GD2? Has GD2 been suppressed because of all previous anti-GD2 therapy? So there's a lot of differences as to why we would pick one trial over the other for each patient. Are there more? Oh, there's more questions. Okay. Um, our our boy, PET negative and MIG positive for past 18 months, is in remission. Primary site is sphenoid maxilla orbit, bilateral vision loss. What should next steps be? That is very interesting that they're PET negative and MIBG positive. We did have patients um, who were PET negative and MIBG positive enrolling onto the DFMO study, and the upfront trial that I showed, and all of those patients are still in remission today. So the MIBG positive could just be mature cells if the PET is negative. If it were possible to get a biopsy of that area, that's a challenging area to get a biopsy of, but that's something that either the DFMO AMXT trial or just DFMO may be possible. It would be important to know if that patient's progressing or not progressing, and are they stable. It sounds like probably stable, so I would think that would be a good option. But again, I'm happy to review that separately. The minimum age for DFMO MX2, great question. So we are, sorry, did I skip that slide? Starting with children age 12 and older for the first 6 patients. Then we'll be going down to patients age 6 and over, and then going down. The FDA has definitely made a change, and a really requiring trials to enroll older patients first, not just in neuroblastoma, but other diseases that we're studying that make it a little bit challenging because that's not the patient population generally. But we are working to try and enroll these patients. But right now it's patients 12 and older. Great question. Is it possible to combine DFMO with lorlatinib in any of your currently enrolling studies on DFMO? Not in our currently enrolling studies, no. But we'll expect our expanded access. But we are prescribing DFMO and prescribing the AMXT inhibitor together for patients at the end of upfront treatment with ALK mutations or amplification of ALK. But we don't have a clinical trial with that combination currently. Is there any new information understood about kids who experience late relapse, such as successful upfront therapy, long-term remission 3 to 4 years before bone relapse, tumor cells hiding, sleeping dormant? Generally, a longer term, a late relapse tends to have a little bit of a better prognosis than an early quick relapse. And we are doing sequencing of patients and really encouraging and trying to have all families of patients do biopsies and sequencing, especially at those relapse time points, so that we can learn what is the difference and why. But I think for those patients, going on to standard of care relapse therapy at that time is appropriate. And again, it depends on where and the extent of the relapse as well. A single spot of relapse, if we can get a biopsy, if we can get them on PEACH trial, if we can get a radiation to that spot, it generally can get them back into remission very quickly and very targeted therapy. Okay, next question. My grandson has stage 4 neuroblastoma, but UK is stopping DFMO. My daughter's beside herself. What can we do? That is a great question. And I would encourage you to talk to Enid and the families. And it is really unfortunate. I have heard that the UK is stopping to support families from getting DFMO. I think encouraging discussions with advocates in Parliament and just, having them relook at the data, relook at the family's needs is really important, and that push, because that's really what happened in other countries and led to DFMO approvals, really inquiring them to look at the data. We know it's a single arm study, but there is a good comparative. And there is a Tanner named patient program. I would encourage reaching out to that as well. And yeah, I think it's a challenge. And, but working with Enid and other advocates, I know that you'll find a solution. Enid can share my email. The question about my email. What are the next steps to have DFMO in Brazil? So we are the naxitamab upfront trial. That second part, the 012 study, will be opening in Brazil. I know Dr. Amber will be working on that next to have that study available. Once that study is available, patients will need to make sure to enroll after radiation therapy onto that trial. And it's at the GRAC Hospital in São Paulo, Brazil. As the next step. Other than that, encouraging working with advocates and working with the government in Brazil to make DFMO available beyond just the World Named Patient Program is also important. And then another question. I know you spoke about not needing to extend DFMO beyond 2 years if a patient is still in remission. Is there any harm in continuing DFMO long term if you want to? Are there long-term impacts of DFMO? So we don't, we have followed patients for over 12 years now with the DFMO, more than that. And we have not seen any long-term impacts of DFMO. We have had some patients that have continued beyond 2 years, although that is not recommended. But I can't answer scientifically whether there is a harm. We know that 2 years is quite safe. I don't believe there would be significant harm in continuing a little bit longer than that, but we don't have any data on that. Can a child still have access to DFMO AMXT if the disease is active, or must it be stable? So they can have active disease as long as it's not actively progressing and spreading. So if they have active bone diseases, lymph nodes, etc., as long as it's kind of stable on 2 scans, that it's still present and active, but not progressing and spreading actively, then they're able to enroll. When is it appropriate to request a liquid biopsy as compared to a standard biopsy? So I would always recommend a standard biopsy first of the tumor, but at the same time, that will give you the tumor full DNA, RNA. At the same time we do a liquid biopsy, that tells us what circulating tumor DNA is present. And that's something that you can follow. So if there's 30% liquid DNA present in the tumor, then we're doing treatment, and then 2 months later, we follow the liquid biopsy. We can see the tumor biopsy decrease. We can also, the liquid biopsy is the tumor DNA in the blood sometimes is very low, it can be detected, so it can sometimes be seen even before a relapse is found. So finding those relapses early is also important to know. Is there a possibility to get DFMO as part of a trial program in Armenia? I don't know. I'd be happy to talk to the doctors in Armenia to see if they'd be interested in participating in, for example, the 012 trial or other trials that we have, or to see, what they might need in terms of support with their government to get approval there. But if somebody wants to put me in contact with them, I'm happy to contact them. More questions? Do you consider post-treatment monitoring should include MIBG scans, and for how many years? Some countries differ. This varies widely among different countries. So our recommendation is at the end of treatment after 2 years of DFMO. So while on DFMO, we do follow scans. at 3 months for 2 cycles, and then at 6 months till the end. And then for their first year off treatment, which is the highest risk of relapse, we recommend a scan at 6 months and at 1 year. And then the following 2 years off treatment, we do a scan at 2 years off treatment and at 3 years off treatment. And then we stop scanning. So that's our recommended scan schedule. And I would, at minimum, recommend following urine, VMA, HVA, or circulating tumor DNA. If a scan isn't possible, at least some non-invasive or less invasive ways potentially to follow. But I think following for that first 2 years, at least off treatment, is important. Some countries only offer ultrasounds. Is this sufficient? No. So we don't believe here in the US that ultrasound is sufficient. Ultrasound only evaluates the local area of disease in the abdomen. The majority of relapses that we see are in bones, and that won't detect a bone relapse. And so it's less radiation, definitely, but it won't detect more common areas of relapse. Okay. Is there any study with flubendazole for neuroblastoma? Not that I know of. I know some people are looking at it preclinically, but I have not seen a clinical trial with that medication currently. Is it financially feasible to access your precision trial or the dendritic cell vaccine for an international patient? For the precision medicine trial, we do have families that have done the biopsy in their home country, and they're able to travel and bring the biopsy. The challenge with that is that if we want live cells, we do work with some home oncologists, especially in Brazil, to have live cells FedExed, but sometimes they don't make it here alive. It needs to be generally within 24 to 48 hours, and depending on customs. But they can bring the FFPE block with them, and then we can send that for sequencing. That can be that does cost, I think, $2,000 for the self-pay, but somewhat affordable. And then we can do the full molecular tumor board debate. All of that work is not doesn't cost anything. And then the molecular tumor board we have with the home oncologist. And then many of our patients have been able to access those medications in their country. So that's worked well with some of our colleagues in Brazil to minimize the cost to the family. The PEACH trial does require more. The vaccine portion is all provided. And I can look into the cost if anyone's particularly interested. There is cost for, I believe, the leukapheresis, the first leukapheresis, and then for this fludarabine, Cytoxan, fludarabine, which are standard drugs here. So there's some cost, but I can have our financial do an international cost estimate if that's of interest. Okay, more questions. In Sweden, our oncologists don't want to help us apply for a named patient program for DFMO. They just say there's insufficient evidence. What can we do? That's a challenge. There are oncologists in Sweden. I was just there in March, April. I was just in Sweden at the Karolinska Institute, and they were very supportive. So I would try talking to the physicians at the Karolinska Institute, and I can try and help connecting you with some of the oncologists there that were very supportive of DFMO. So I think there are some, it just is a matter of talking with the correct physician. Is high dose DFMO better for multiple relapse cases? That's a great question. One of our studies, 014, was looking at high dose versus standard dose. We don't know the answer to that completely. It does seem like the dose that we're using is adequate. I think more important than the higher dose DFMO is going to be the combination. I'm hoping that combination with AMXT or with venetoclax, but I think it's going to be more important to combine it with a newer agent to get more of an effect than just increasing the dose. Food, okay, more questions. Food to avoid in remission period for polyamine uptake. That's a great question. So foods that have high levels of polyamines, there is a kind of a food chart that shows the levels of polyamines in foods. Orange juice and grapefruit juice, pure, have high levels of polyamines. But when we measure urine polyamines in patients, it's hard for a child to eat enough of one food group or polyamine intake to really change their blood level very much. And so we haven't, and it's really more important for these children to grow. And so we haven't really restricted foods. These children will eat maybe, a small glass of orange juice isn't going to change their pollen. They would have to eat multiple glasses of orange juice specifically to change their polyamine levels in the blood. And so we haven't really recommended restricting diet based on polyamines. But if anyone, everything in moderation, small amounts of orange juice or grapefruit juice are fine. Small amounts of fresh tomatoes, fine. Again, they're not going to really eat enough to change that blood level. Okay, last question, it looks like. When a patient relapses after chemoimmunotherapy, what do you consider first, changing the chemotherapy backbone or switching to anti-GD2 antibody? I would do both. If they're resistant to irinotecan and an antibody, I would move away from all three and try and find a medication. Something like if they were on irinotecan or gentuximab, I could, if we wanted to try another GD2 therapy, probably the tipifarnib with the naxitamab as a different anti-GD2 with a different mechanism, or really sequencing that patient's tumor and trying to find which trial might be best. There are, I didn't talk about here, but there are a lot of newer CAR T cell trials, other studies for neuroblastoma available out there. And when we're looking at our patients and looking at the sequencing, we want to look at everything that's available to that patient and making sure that whether it's one of our trials or a different trial, that that patient's going to the right therapy is what's most important. And there are so many newer things available for neuroblastoma now. It's an exciting time that our international colleagues are all working to try and find that. So I think that's the most important piece. And I think I've answered all the Q&As.
Yeah. Wow, you had so many.
Yeah.
Thank you so much, Dr. Sholler, for your time, your insights. Very inspiring. Your continued leadership, of course, your work through the Beat Childhood Cancer Consortium, and your commitment to advancing initiatives, innovating clinical trials, bringing hope to families and around the world and help them move the field forward. Wow, thank you for that. To everyone join us today, thank you. Your questions, your engagement, your commitment, and to learning are what makes this community so special. Together, we are building knowledge, connections, and hope. Each month, we are reminded that progress happens because of collaboration among researchers, clinicians, nurses, advocates, and families. Thank you for being part of this effort. As we look ahead, our next webinar will take place on July 6th when we will have Dr. Lucas Moreno. He will share updates on the from SALPEN and discuss ongoing efforts and developments in neuroblastoma research and clinical trials across Europe. We hope you'll continue to join us and as we bring together experts from all around the world to share knowledge, insights, and progress. Until next time, take care, stay informed, stay connected, and remember, together we can change the fate of children with neuroblastoma. Thank you.